All right, let's move to the next topic, disparities and inequities throughout diagnosis, treatment, access to clinical trials. Coming back from ESMO, one of the issues that this was very important to Europa Dana while we did our advocacy and action there. And in Europe, obviously, there are regional disparities and inequities. In the US, I think many of our disparities and inequities really revolve around culture, attitudes, access, economics, and it's of deep concern to all of us because early diagnosis and early treatment can be the difference between life and death.
And I would just add and agree to that, you know, disparities are just across the continuum, and it just touches people's lives in very different ways. The one thing that you didn't mention also is sort of language and literacy. And I think we have to make sure as we're developing resources and support that the resources are accessible. It is part of access, but I think traditionally when we think of access, we're thinking of access to healthcare and access to other kinds of things, financial resources. But keeping in mind that also a lot of women are dealing with providers that may not speak their native language. Just it could be that basic and that complex. So the disparities cross, you know, cancer, culture, literacy, ethnicity, geography. Many of us are very familiar because we live in more metropolitan areas or urban areas, but the lion's share of the country in the US is much more suburbia or rural. And how many people have we all heard from over time that need to travel an hour and a half or 2 hours to get to their doctor? And that also can create an inequity in terms of the kind of care that they get, the access to the care that they want versus the practical nature of what is possible to integrate into their lives.
And I think you just identified many areas where we're not consistent here in the US. And how we deliver health care. We all think our system's the best, but it's not because we're still missing huge sort of holes in the population. Our particular clinic has gone to taking our physicians and nurses out to the outlying communities. It works somewhat okay, but it's still not the best because we still have a large population. And also with the physicians too, you know, they have to see X number of patients because they have a business to run. And does that always facilitate all the time for them to sit and have these conversations with their patients? And I don't know how we get there, but it would be nice if we could get that looked at and have one of the questions answered in our system.
Vital Options has been doing a project with the Armenian community and radiation therapy. So what do I learn recently? There is no word in the Armenian language for radiation therapy, so they call it lightning. Furthermore, what was so startling is the children are saying, please don't let my mother or father know that they have cancer. So in some of these cultures, what's happening is that these patients, and they must know intuitively. So I'm at the radiation therapy center observing this, and these are patients coming in for cancer treatment that they call lightning, and they are told that they're there for any number of reasons. And I remember, you know, in Europe and countries like Russia and even France for a long time, there were certain countries that were just more stigmatized when it came to cancer than others. But right here in the United States, with the influx of many of these other cultures where cancer is so taboo, and I think about the impact that has on really the effectiveness of treatment and how disempowering that is, and how it negates progress, that it negates the fact that you can overcome cancer.
It's true in Japan as well, and I think that you know, the stigmatized aspect of cancer, and especially breast cancer, is a real impediment to doing effective advocacy work, because if you can't talk about it and use the terms, it really creates that wall. If you think back to when advocacy really started getting going, you know, and if you want to look at, you know, Betty Rollins' book, and, you know, where she was one of the first people to use the term, which, as she says, and I've heard her speak many times, you could say the word breast and you could say the word cancer, but you couldn't say the words breast cancer together. And it was one of the first advocates wanted to put an ad in the New York Times for a breast cancer support group, and they said, well, we can't print that in the New York Times. Can you just call it diseases of the chest wall? And it wasn't that long ago. But you can see how once you start, breaking those walls down, how it makes our work much easier. That doesn't mean it's easy, but it makes it much easier. You have to know what those walls are.
Lisa Schlager, facing a risk of cancer empowered, and I too am BRCA positive, and I'm what they call a previvor, so I have a slightly different perspective on all of this. But going back to the whole issue of culture and cultural differences and the way things are dealt with. Rochelle Schwartz is not here from Sure Share It, but something that struck me is for women in the Jewish community, especially the religious Jewish community, a history of breast cancer or any other type of cancer in that population is seen as a scarlet letter. Young women in that community are considered not good marriage material, because if they're known to have a family history. And I think that type of mentality is probably more widespread than we realize in other groups.
I came out of that community, and I remember in my 20s, a guy out of that community, his exact words to me were, "Oh, I really couldn't be involved with a woman like you because you're not genetically perfect." I will never forget it.
What the Sisters Network is doing in regards to really tailoring their message to their audience, I think that is critical as we move forward, that there has to be sensitivity to the nuances of the different groups culturally, economically, for us to succeed in addressing the unique needs of each individual group. Not to say that we shouldn't all have a common mission and work together, but you want to, I think the patients and constituents want to work with people who get them, who understand where they're coming from.
There's one other issue regarding this whole BRCA mutation, and so much emphasis was put on the Jewish Ashkenazi community that it did a disservice to the African American patients, where we have a strain, where we have found it in Latinas, yet another strain, and it's like when you take a mutation early on, and we understand because of the pogroms, we understand the story of how it became so concentrated within that community. But it was very disturbing to think that we have so classified a mutation that as the project expands and the research and the genome expands, that we understand these other groups that are also impacted.
Absolutely. There's so much more research needed on those populations, and it's been designated as the Jewish problem, and it's not. It's so much more than that.